coronary artery anomalies are rare. The incidence has been reported as 0.024% of the population, and they have been reported also in 0.6 to 1.2% during cardiac catheterization. They may be associated with angina, with myocardial infarction, and even with sudden death, particularly when the coronary artery is interposed between the aorta and the pulmonary trunk. The single origin of a coronary artery can occur when there is either a single orifice, as in this anatomical specimen, or sometimes one of the coronary arteries arises from the other one. For example, there can be an aberrant right coronary artery arising from the proximal LAD. It is interesting that the course of the coronary artery can be in front or behind the pulmonary trunk. In either situation, there can be compression of the vessel, and myocardial ischemia can result. There are many anatomic variations and anomalies of the coronary arteries, the most common being the two coronary arteries arising from the same sinus of Valsalva, as noted in these four diagrams. Note that it may come from the left, or it may come from the right sinus of Valsalva, or in between the two sinuses, as indicated in the third diagram. And the last diagram shows acute angulation that may be seen when the left coronary artery comes off the anterior sinus of Valsalva. When the left coronary artery arises from the anterior sinus of Valsalva, it may course interpose between the pulmonary trunk and the root of the aorta, as indicated in this diagram. In this selective coronary arteriogram, one can see the abnormal course of the left main coronary artery, which curves cephalically. In the last two angiograms, we see narrowing of the circumflex branch and narrowing of the left main coronary artery, and this is because of the interposition between the pulmonary trunk and the ascending aorta. This may be a cause of sudden death. Sudden death is usually related to a fatal arrhythmia. It can be associated with a number of cardiac conditions, including a prolapse of the mitral valve, but it can be also the result of ostial narrowings, spasm of the proximal coronary arteries, and abnormal entrapment of the coronary arteries between the pulmonary trunk and the ascending aorta, particularly during exercise when there is increase in the caliber of the pulmonary trunk. The interposed coronary artery can become compressed by the aorta and the pulmonary trunk, and sudden deprivation of left ventricular blood flow will result, and this will lead to sudden death. This is the Bland-Garland-White syndrome, an infant with cardiomegaly and myocardial ischemia. Note the globular enlargement of the heart, primarily due to enlargement of the left ventricle and normal pulmonary vascularity. An aortogram shows retrograde perfusion of a left coronary artery, which ends in the pulmonary trunk, which is seen in the third image. Note the marked enlargement of the right coronary artery, which arose normally from the root of the aorta. In the lateral aortogram, one can see the huge right coronary artery and the retrograde filling of the left coronary artery. The last two images correspond to a pulmonary arteriogram. Due to the fact that the pressure in the right coronary artery is higher than the pressure in the left, it is not possible often to see the origin of the left coronary artery from the pulmonary trunk. The flow is from the aorta to the pulmonary trunk. There is a steal phenomena, and that leads to ischemia of the left ventricle. In this patient, the left internal mammary artery was anastomosed to the left anterior descending branch of the left coronary artery. Interestingly, the patient developed angina when exercising the left arm. An angiographic examination revealed in this second image that upon injecting the left anterior descending, one can see a retrograde flow from the anastomost lima into the subclavian artery. And the third image shows antegrade filling of the left subclavian artery, which was occluded at its origin. So the Steele syndrome occurred from flow diversion from the heart into the left arm via a retrograde filling of the left internal mammary artery.